Hi guys, good evening. I hope you are able to see me or able to hear me. One second. Hi guys, good evening, good evening. Hi, good evening, Mansoor. Liaquat, good evening. I hope you are able to see me or able to hear me. So, let's continue our discussion on trauma. So, yesterday we spoke about the ABC protocol, that is your airway, breathing, circulation. Now today we'll be talking about disability limitation with expose and examine. Okay, so today we'll talk about all the details that we usually talk about in our trauma discussion, so try to keep it to the same point. Okay, I think the voice is good from my end, it looks fine. Yep. Yeah. Okay. I hope you are able to hear me. Chalo. So, today we'll be talking about the protocol D. The protocol D is about disability limitation. It is going to be disability limitation. So, we'll talk about the disability limitation. So, when talk about disability limitation, how would you look for the disability limitation? We have two things for the assessment. In the assessment criteria, the first thing that you would do is going to be a GCS scoring. So we'll use or calculate the Glasgow Coma Scale. So look at the GCS scoring system of the GCS scale, that is Glasgow Coma Scale. That is the first thing. And second, we will do a pupil assessment. We'll do a pupil assessment. Now we have both in one single context, right? So today we'll be talking about how do you calculate GCS scores and what is the pupillary assessment and how are we going to build across it in terms of trauma assessment. So when we talk about the GCS scoring system, so we'll talk about in detail about the Glasgow Coma Scale. So GCS scoring system works on three principles. We look at the response in the form of eye opening. So look at the response in the terms of eye opening. We look at the response as verbal and we look at the response as motor response. So we have the three criteria what we call as EVM. E stands for the response that is in terms of eye opening. We see the response in the form of eye opening. We see the response in the form of verbal, that is verbal response. And the most sensitive criteria is going to be the motor response. The most sensitive criteria is going to be the motor response, and this is what you calculate your GCS score as E, V, and M. Now, when you look, sorry. So when you look at these components, we'll try to calculate how the eye response is, looked after, how is the verbal response is looked after, and how is the motor response looked after, right? So when you talk about the first criteria, that is going to be your eye opening. We'll talk about the eye opening response. Now, in an eye opening response, you will go down to the patient. Let's say a patient has come to you after a trauma and you want to do a GCS assessment. Now, if he's sitting and he's talking to his friends with his eyes wide open, so we say the eye opening status when you look at it, if the eye is already open or the patient opens spontaneously, if there is a spontaneous eye opening, a score of 4 is given. That is the highest possible score in a eye opening that is going to be present. Now let's say you go down to the patient. Patient is lying down on a stretcher, or let's say he's lying down on a trauma bed and his eyes are closed. Now as you walk towards the patient, if he suddenly opens, that means he's aware of his surroundings. So his, the cognitive functions, everything is being properly retained. So hence he's pretty much fine. So his response is 4. Let's say you walk towards the patient is not able to assess the environment. Obviously, when you see a patient's eye is closed, you will try to call out his name and see whether he is going to open his eyes or not. Now, if on just giving a verbal input, that means you're giving a noise or a sound and you're calling his name and he opens, that means he's still better. So if the eye opening is to speech, if there is an eye opening to speech, a score of 3 is given. Even if the patient is not opening his eyes when you call out his name, the next logical thing is to exert some amount of pain to see whether he's opening with a painful stimulus or not. So if there is an eye opening to a painful stimulus, a score of 2 would be given. And even then, if the patient still doesn't open his eye, we call it as no response, right? So when there is no response, a score of 1 is given, right? So when you're assessing the eye opening in a patient after a trauma, the maximum possible score is going to be 4 and a minimum possible score is going to be 1. So if he is opening the eye spontaneously, score of 4, to speech is 3, to painful stimulus 2, and no response, it is going to be absolutely 1. Goel, we have sir starting surgery residency soon. Please make a video on how to go about it in the first year and manage the reads. Absolutely, will come up with the surgery component for residency also. I will address, if you are joining, all the guys who are joining the first year of surgery residency, a big shout out to you. You have chosen an amazing branch and an amazing form of life. Congratulations and kudos. And yes, we will discuss how to do about our residency. So when you're joining your residency, this is for you to understand that what to be done and what not to be done. We'll talk in detail about it. Don't worry. Right? I got your back there also, guys. So absolutely. Now, we'll talk about the second thing, that is going to be your verbal response. So we'll assess the second thing is going to be the verbal response. The second thing that we are going to assess, it is going to be the verbal response. So when you're looking at the verbal response, obviously if the patient has come to the casualty, you would like to have some conversation if the patient is conscious, right? Now, you'll start, obviously you can't talk about, some nonsense. So you'll talk about something that makes sense, right? So the first thing you will, when you are making a verbal conversation, it will be about time, place, and person. That is he oriented? That, when you talk about time, place, and person, time is like, you should understand what time of a day it is. Is it morning, afternoon, evening, or night? Second, when you talk about place, he should realize that he is in your hospital casualty, not in some 5-star hotel. Third thing, he should recognize the person who has brought him to the hospital, whether it's a known or an unknown person. Is it a relative or a non-relative? If he's able to recognize it, then we say it is absolutely fine. So if it is oriented, if the patient is oriented to 3 things, that is time, place, and person. If the patient is oriented to time, place, and person, a score of 5 is going to be given, right? On the other hand, if the patient appears to be confused, that means he's thinking, he's not able to understand what time of the day it is. He does not recognize the person who has brought him to the casualty. He's probably thinking that the person who has brought him to the casualty is not his wife, or he's thinking it's a servant or somebody. That's a big mishap that a patient can have. So patient is confused, right? He's not able to understand the time, or he's thinking he's in a 5-star hotel, not in your hospital casualty, a big confusion status. A score of 4 is given. On the other hand, if the patient starts abusing you, he starts using words which are inappropriate or an inappropriate response. You're talking about, let's say, what do you like to eat? And he says, my favorite car is Ferrari, right? So that means there's no response. There's no appropriate response to an appropriate question. And if he's using those words, abusive words also, we'll call it as inappropriate response. If you're using inappropriate words, he's becoming aggressive, using inappropriate words, a score of 3 is given. On the other hand, the patient is trying to tell you something, he's trying to talk, but his words are not being heard. That means he's not able to make any sense to us. He's trying to make a communication, he's trying to make a conversation, but the words that is coming out of his mouth are not getting into your ears, so you're not able to understand it. Like, that all that moaning sounds, and all that, no, all the sounds he's making, so not able to understand. So we call it as incomprehensible sounds. It is called as the incomprehensible sounds. If there is presence of incomprehensible sounds, a score of 2, and let's say if the patient goes on mute, that is, there's no verbal response, the minimum response that you can have is going to be a score of 1, right? So we had the eye opening and the verbal response. As you can see, the eye opening maximum is 4, minimum is 1. The verbal response, the maximum is going to be 5 and the minimum is going to be 1. The most important that we have is going to be our motor response. So when you look at the motor response, when you talk about the motor response, again, one of the most important criteria that has to be assessed, right? Now, in a motor response, if the patient obeys command, if the patient obeys all the commands that are given by you, that means you're asking to raise the hand, touch the nose, move the fingers, move the toes. If the patient is able to do whatever you're asking him on a motor scale, if he's obeying command, a score of 6 has to be given. Obeys command, score of 6 is given, right? On the other hand, when the patient is not able to obey command, you've said, to move the hands and toes and all, if it's not doing so, you will give a painful stimulus. Usually we give right in the center or on the, the orbit per se. We will see if the patient's motor response is good, he will make a purposeful movement towards the painful stimulus and try to move your hand away. He is localizing from where the pain stimulus is present. So if he localizes to pain, if he moves to if he moves his hand or moves his limb to the site of pain, is able to reach all the way to the site of pain, which is also called as localizes to pain. If he localize to pain, a score of 5 is given. A score of 5 is given, right? On the other hand, when you are giving a painful stimulus, the patient is now trying to reach, but he's not having enough amount of motor strength, right? But he's making a purposeful attempt, he's making a purposeful reach, and he's not able to reach, but there's some amount of flexion. So he's trying to reach to the site of the pain, and that flexion indicates a score of 4. So if there is flexion from pain, if it is flexion response to pain, if there is a flexion response to pain, a score of 4 is given, right? Now, on the other hand, until this point it is fine. Patient obeys all the commands, a score of 6. If he moves to a side where the pain is occurring, a score of 5. If there's a flexion response but is not able to reach all the way to the site of the pain, so there's a purposeful response but not a complete response, then a score of 4 is given. Then you have something called as the decorticate and the decerebrate rigidity. The patient will have decorticate rigidity, that is on a painful stimulus. Now, decorticate rigidity is what we call it as a flexion rigidity. This is what we call it as a flexion rigidity, a score of 3. So you will see a patient who's having a decorticate rigidity, you will see his components are in a flexed state. It's a flexion rigidity. On the other hand, if it is even more worse, it is going to have a decerebrate rigidity. There will be presence of a decerebrate rigidity, that is called as an extension rigidity. That is referred to as the extension rigidity. If there is an extension rigidity, a score of 2 is given. And when you see this patient, you will see as if, he is free from the world. You will see he is in extension state. His arms are extended. So you will notice you'll notice that his arms are extended, his legs are extended. So it's an extension state. It's an extension rigidity. It is called as a decerebrate rigidity. So decorticate rigidity is a flexion rigidity. Decerebrate rigidity is an extension rigidity. And the worst case, even worse than that, there'll be no response. Now, if there is no response, a score of 1 is given. If there's no response, a score of 1 is given. And this is how the motor response is going to be present. Okay? So this is all in all how you calculate your GCS scoring system. So in the GCS, we spoke about in terms of eye opening, we spoke about the verbal response, we spoke about the motor response. So as you can see, the highest response that you can get for an eye opening is going to be 4. For verbal, it is going to be 5, and motor, it is going to be 6. So when you talk about the entire GCS scoring, the entire GCS score works on this E4, V5, and M6 principle. We speak about E4, V5, M6, and this is your entire GCS score that you are going to calculate. Now, when you look at the 3 components, that is the eye opening, the verbal response, and the motor, if they ask you which is the most sensitive criteria of GCS, the most sensitive criteria, when you look at the GCS score, it is the motor response. It is going to be the motor response. The most sensitive criteria is going to be your motor response. Now, if they ask you what is a maximum GCS, the maximum GCS score that is possible, it is going to be 15 by 15. That is E4, V5, M6. When you add up, you'll get a score of 15, right? If they ask you what is the minimum GCS score possible, so we have already looked at it. It is going to be 3 by 15. It's going to be 3 by 15, right? Let's say a patient was presented to you with severe facial fracture. There is a severe facial injury rather than say fracture. The severe facial injury with bilateral eyelid edema. Now, when you have a patient who is going to have a severe facial fracture with both the eyelids which are swollen, and you are asking the patient to open the eyes. Now, obviously, if the eyelids are swollen, he will not be able to open the eyes. So, does that make the eye response to be 1? The answer is no. In such patients, whenever you are not able to assess, I will say it is NT, that is non-testable. The same thing validates when you're looking for a motor response and you have limb fracture. So when you say eye response here, the eye response will become NT. NT means non-testable. Same thing if there is in polytrauma, if let's say both, that is all 4 limbs are fractured. If all 4 limbs are fractured, what will become to your motor response? The motor response will also become NT, that is non-testable. That will become non-testable. You cannot see, Mansoor, there is no score called as 0 in GCS. GCS does not like the word 0. GCS says the minimum is 1 and the maximum in E is 4, V is 5, M is 6. So GCS tells you in life that there is no option for being in 0. The minimum that you can drop down to is 1, and then you will have to pick up from there onwards. Okay? So this is in terms of polytrauma. On the other hand, let's say if a patient is intubated. If the patient is intubated, and an intubated patient, if they ask you what is the GCS, so here the verbal response will also be non-testable. You can say NT. So whenever you are not, so these are the sites where you will see it is NT. So if I give you a patient who is having polytrauma, with severe facial injury, involving both the eyelids, they are swollen, all four limbs are fractured. All four limbs are fractured and intubated. Can you tell me what will be the GCS for this patient? A polytrauma patient with severe facial fractures with both the eyelids are become edematous, all four limbs are fractured and the patient is intubated. What do you think is going to be his GCS score? So what will be the E, what will be V, and what will be the M? Remember, in all these three conditions, E will become non-testable, VT will become non-testable, motor will become non-testable. So in such scenarios, the GCS will become non-testable. It will become non-testable. Clear? So if they want to trick you, no, this is how they ask you questions, right? So try to create relevance out of something which does not have any relevance. If you're not able to calculate GCS, there's no relevance at all. But that irrelevant will become more relevant when it is asked in exam. So all your exam questions are to understand which is the most irrelevant point. Okay? So keep that in mind. So if you're preparing for a competitive exam. Now this is how you look at for the GCS criteria. Now another thing that they can ask you is, at what GCS there is increased risk for coma? There's an increased risk for coma if a GCS is less than or equal to 8/15, and that is why we say whenever you have this, there is an indication for prophylactic intubation. What is the indication for your prophylactic intubation? The prophylactic intubation is done when a GCS becomes less than or equal to 8/15. If the GCS becomes less than or equal to 8/15, so this is on the basis of GCS that you're going to look across, right? Now, when you continue across in the GCS, we have something new called as the GCS P score. Now, when I say GCS P score, in a GCS P score, we are looking for the pupillary assessment score. The word or the letter P stands for, it is going to be the pupil assessment score. This is going to be a pupil assessment score. So in a pupillary assessment score, how do we categorize it? Now say if bilateral pupils, if it is responsive to light, a score of -2 is given. That means if both the pupils, when you put light, they constrict. If you're putting light in one pupil, this is constricting, the contralateral pupil also constricts. If both the pupils on putting light, if they become responsive, a score of -2 is given. If unilateral, only one. If there's unilateral pupil response, the other one is not responding. If there's a unilateral pupil response to light, a score of -1 is given. A score of -1 is given. Sorry, if both the pupils are responsive to light, we give a score of 0. You're saying responsive to light. No. If only one pupil is responding, it is -1. If bilateral pupil are non-responsive to light, right? If both the pupils, bilateral pupil non-responsive to light. If bilateral pupil non-responsive to light, a score of -2 is there. A score of -2 is there, right? So if both the pupils are responsive to light, a score of 0. If any one pupil is responding, the other is not responding, -1. If both the pupils are not responding, it is going to be -2. So when you look at the GCS P score, in a GCS P score, if I have to elaborate the entire scoring system, I would say it is E4, V5, M6. We're talking about the maximum. P will become 0. Pupillary assessment, 0 is the maximum score. So when I say what is the maximum GCS P score possible, the maximum GCS P score that can occur is going to be 4 plus 5 plus 6 plus 0, which is still be equal to 15/15. Would still be equal to 15/15. But if I come down to the question where I'm asking you what is the minimum, what is the minimum GCS P score possible? The minimum GCS score, E is going to be 1, verbal is going to be 1, motor is going to be 1, and this is going to be -2. The minimum is -2. So total will come down to as 3, sorry, the total is going to come down to as 1 by 15. So obviously 3 minus 2, it is going to be 1 by 15. So 1 by 15 will become the minimum GCS P score that is possible. Now based on this, whenever a patient is going to have a head injury, we have a categorization of head injury based upon the Glasgow Coma Scale. So how do you categorize a patient of head injury? We talk about the head injury classification. So we talk about the head injury classification. This is on the basis of GCS score. On the basis of Glasgow Coma Scale. So categorization of head injury based upon the GCS score. Now based upon this, I can categorize the head injury into minor head injury. I can categorize them into mild head injury. We can categorize them into moderate head injury, and then to a severe form of head injury. So minor, mild, moderate, and severe. So we'll categorize them into minor, mild, moderate, and severe. In order to call it as minor, remember the GCS of the patient must be 15 by 15 with no loss of consciousness. With no loss of consciousness should be noticed. In a mild, you can have a patient who's having a GCS of either 14 by 15 or it is 15 by 15, but this time the patient has loss of consciousness. So there is with loss of consciousness will be maintained. When it is moderate, you will see a GCS score of anywhere between 9 to 13. For a severe head injury, the GCS score is less than or equal to 8. And that is when we say that it is important to understand that whenever a patient's GCS drops less than or equal to 8, that is an indication for prophylactic intubation with increased risk for coma that you have to explain to your patient attendants, right? So this is how you categorize, calculate, and look for your GCS score. Now, along with this, you have understood the head injuries, or I can say the disability limitation criteria. The last one is the expose and examine. So when we say the last criteria in our ABCDE protocol, it is expose and examine. It is expose and examine along with environmental control. Along with that of the environmental control. Now here one of the most important things that we have to understand, that you have to examine from head to toe. There has to be a quick examination. There has to be a quick examination from head to toe. Now in order to do so, you have to undress the patient. There should be no articles. Remember, the patient has to be completely undressed to examine it. And the most important is the examination of back. Now, when a patient is lying down supine in a patient of polytrauma, examination of back holds a very, very high importance, right? Now, you cannot simply examine the back because the patient has multiple fractures or multiple injuries that are there. So you have to take care of that and then continue to examine. So in order to do this, you have a technique which is called as a log roll technique. Now in a log roll technique, let's say this is the patient who's been lying down supine, and we have decided for the examination of the back. Let's say this is the patient who has been lying down supine, and we have decided for examination of the back. What are how many or the minimum number of people required to do so? I would require 1%. I would require 1% to stabilize the cervical spine, 1% to hold the lower limb or a fractured segment, and I require at least 2 people to flip the patient and examine. So the minimum number of people required for a log roll technique. The minimum number of people required for a log roll technique is going to be 4. There was some controversy where they said it is minimum is 3, then they came out to be 5. Currently, we say the minimum number of people required to conduct a log roll technique. 1, it is to stabilize cervical spine. Stabilize the cervical spine. Another one, it is to stabilize lower limbs, especially if there is associated fracture. The other two people that you have, it is to turn the patient around, to turn the patient, stabilize the upper limb, stabilize the upper limb, and examine. For this, you require the other two people. So total number of people required for a log roll technique as of today, it is going to be 4. Now this completes your entire discussion on our primary survey. So when we had started the discussion on the primary survey, so in the primary survey, we had a protocol that is A, B, C, D, and E. Now in this A, we spoke about how do we manage airway. B, we spoke about how are we going to manage the breathing. C, circulation. D is disability limitation. E is going to be that is expose and examine. Another very important thing that you need to understand is when you're looking at the examination part, prevention of hypothermia is also going to be very, very important, because at the end of the primary survey, you need to understand that there is a very important triad that you have to prevent, and that is what we call it as the lethal triad of trauma. That is what we call it as the lethal triad of trauma. Now, what is this lethal triad of trauma? What is this lethal triad of trauma? When we say the lethal triad of trauma, it consists of 3 things. Number 1, it is associated with metabolic acidosis. Number 2, excessive blood loss will result in coagulopathy. And the last nail in the coffin is going to be hypothermia. So in a patient of trauma, how are you planning to prevent this lethal triad of trauma? So to counter the metabolic acidosis, we have told that I'm going to give Ringer lactate. In order to counter the coagulopathy, so whenever I'm going to give PRBCs in FFP as well as platelets, the ratio that we maintain is 1:1:1 to prevent coagulopathy and to prevent hypothermia. Whichever Ringer lactate that you're going to infuse, I am now going to put it as warm fluids. So I will do a warm fluid resuscitation. So this warm fluid resuscitation helps us to combat hypothermia. We'll keep the patient covered in blankets and also in warmers so that you are able to address. The goal is not to bring down the core body temperature less than 37 degrees Celsius. So this is how you're going to look at the lethal triad of trauma and try to prevent every single time you are dealing with a patient of trauma. So we started the entire components of our resuscitation and then we dealt. So the whole objective in trauma that we have learned so far, it is to address this lethal triad of trauma, and we are fighting every single decision that we make so that the patient does not land up in your lethal triad of trauma. Now, once we have done with this, there is something called as the trauma scoring systems, right? So we'll talk about a lot of trauma scoring systems. We'll talk about its importance and how they are done, and then we'll try to understand its clinical or practical implications also. So we're talking about the trauma scoring system. Now, one of the major reasons that it came up with these trauma scoring systems, it is to have a uniform assessment. Now, when you have a uniform assessment, you can have a uniform protocol. And when there's a uniform protocol, you can measure the outcomes to decide whatever you're doing. Is it going to be important or not? Is it going to make a difference or not? If it is not making a difference, you'll change. Otherwise, you'll continue to evolve. The best thing that I can tell you about, there's a crash trial which came across, which said if the patient's systolic blood pressure is less than 100, and if the heart rate is more than 100, start the patient on tranexamic acid at 1 gram stat, and every 8 hourly you repeat 500 milligrams of tranexamic acid. Now, giving tranexamic acid, which is a fibrinolytic agent stabilizer, what it does is it controls the hemorrhage and the outcome of that particular component, or I can say the outcome of the patient who has underwent trauma with bleeding is better using tranexamic acid, right? But damage control surgery is a protocol that you're going to implement when you're not able to achieve your primary goal. We'll talk about it, damage control surgery, don't worry about it. Okay? So when we talk about the trauma scoring system, one of the major trauma scoring system that you have is going to be your revised trauma score. The revised trauma score is also called as the RTS scoring system. The revised trauma score is also called as your RTS scoring system. So what does it comprise of? So when you talk about the revised trauma score or the RTS scoring system, now it consists of three important components that you have. The first important component is going to be the Glasgow Coma Scale. It comprises of Glasgow Coma Scale. So when you look at the GCS scoring system, based upon the GCS, if a score is anywhere between 13 to 15, if the score of GCS is anywhere between 13 to 15, we give an RTS score of 4. If the GCS is between 9 to 12, if the GCS is between 9 to 12, we'll give a score of 3. We'll give a score of 3. If it is between 6 to 8, if it is between 6 to 8, a score of 2 is given. If it is between 4 to 5, if it is between 4 to 5, a score of 1. And I said the minimum GCS possible is 3. If a score of 3 is given, a score of 0 would be given, right? So this is how on the basis of RTS scoring system, we have a score of 13 to 15, we give an RTS score of 4. If it is between 9 to 12, we'll give an RTS score of 3. If it is between 6 to 7, we give an RTS score of 2. If our GCS is between 4 to 5, an RTS score of 1. And if the GCS 3, a RTS score of 0. Lower the score, poorer is the prognosis. The first one is your Glasgow Coma Scale. The second thing that we will consider, it is going to be your systolic blood pressure. And this systolic blood pressure we'll look at as millimeters of mercury. Now on a systolic blood pressure, if it is more than 89 millimeters of mercury, we give a score of 4. If it is anywhere between 76 to that of 89, if it is between 76 to 89, a score of 3 is given. If it is between 50 to 75, 50 to 75, a score of 2. If it is between 1 to 49, if it is between 1 to 49, a score of 1. If systolic blood pressure is not recordable, a score of 0 is given, right? So if a systolic blood pressure is at 89 millimeters of mercury or above, let's say 90 actually, is going to be 4. If it is between 76 to 89, it is a score of 3. If it is between 50 to 75, a score of 2. If it is 1 to 49, a score of 1. And if there is non-recordable systolic blood pressure, a score of 0 is given, right? So this is in terms of systolic blood pressure. The third component that you will consider in a revised trauma score is going to be our respiratory rate. We'll take respiratory rate into consideration. That is going to be number of breaths per minute. We call it as CPM, that is cycles per minute. How many breath cycles is the patient able to take per minute? If it is between 10 to 29, we say a score of 4 is given. If it is more than 29, a score of 3 is given. If it is less, that is 6 to 9, a score of 2 is given. If it is 1 to 5, a score of 1 is given. And if there is no breaths, a score of 0 is given. A score of 0 is given, right? So all these are going to point out towards the possible outcome of our patient. All these are going to point out towards the possible outcome of the patient that you're looking at. If the respiratory rate is 10 to 29, we say it is fine. More than 29, obviously there is tachypnea and there is labored breathing causing carbon dioxide washout. 6 to 9 is going to be brady, that is going to cause retainment of the carbon dioxide. So either ways, you're looking at all these are poor prognostic factors. So when you look at the revised trauma score, so when you say the RTS scoring, when you have calculated the entire score, basically the RTS score that you look at, the RTS score will be anywhere between 0 to 12. So the prognostic index is going to be from poor to excellent. A RTS score of 0 indicates a poor prognosis, and RTS score of 12 indicates the best possible response that you can expect. Then we have something very interesting. We have something called as the injury severity score. We call it as ISS. Now ISS is what we call it as the injury severity score. Now this is something which is universally accepted. A lot of trauma centers use it. All the data that we conduct or occlude, or the data that we are gathering, is going to be from your injury severity score, which is called as an ISS. So when we say an injury severity score, the basis of calculating the injury severity score, how do we calculate it? Now injury severity score is explained as the sum of the three. We have the sum of the three highest square. It is the sum of the three highest square. What is the sum of the three highest score? That is something that we need to understand. We say it is going to be whatever this parameters that have, it will be a square plus b square plus c square. I know it sounds like, going back to your maths lectures. It is not. We'll talk about what is this maximum or the highest severity scoring systems and all that, right? So how do you calculate all this, right? Now, in order to calculate this, we have an abbreviation for all the following components that we have. So the first thing, in order to understand the injury severity score, you have to understand the concept of AIS. And now AIS stands for an abbreviated injury scale. It indicates that it's an abbreviated injury scale. Now what is this abbreviated injury scale? It is going to designate each number to that of the body parts, right? So according to abbreviated score that we have, we have the AIS digit on one side. We say AIS first digit that you're going to use it, and on the basis of body region. On the basis of body region. Okay. Okay. So it is going to be the first digit that you're looking at and the body region that is going to be involved. Right. So based upon this, we are going to look for the component. Now, if you have the digit as 1, it denotes towards the head of the patient. If you have a digit which is 2, it denotes towards the face of the patient. If there is a digit of 3, it denotes to the neck of the patient. 4 indicates thorax, nothing spectacular, it is in the same order. 5 indicates abdomen. 6 indicates spine. 6 indicates spine. 7 indicates upper extremity. And 8 indicates lower extremity. 8 indicates lower extremity, and 9 if it is unspecified. So the first thing, whenever we say that we are talking about an AIS digit, that indicates the site of the injury, not the score of the injury. Do not get confused. Then you have the severity score. Now, based upon the index scoring, we have score on one side, severity on the other side. We have score on one end, the severity on one end. Just to make more sense out of it, I'll give you an example of whatever component that we're talking about. So scoring on one end, severity on other end, and we'll quote an example to understand what we are dealing with, right? Now, for example, we have a score of 1, which is called as minor injuries. What classifies as minor injury? For example, if a patient is having a single rib fracture, if there's a single rib fracture, or I can say patient is having mild aberrations, grazed aberrations, small laceration, all that a score of 1. A score of 2 indicates we are talking about a moderate injury. Now, moderate injury examples is like testicular avulsion. Now, where you can see the scrotum skin is grazed out, any testes are exposed, but testes are healthy. That is a score of 2. Score of 3 indicates it is serious. Now, we talk about a serious injury, example like uncomplicated hemothorax. Patient is going to have hemothorax. Then you have a score of 4, which is severe. Now, which is severe, for example, we're talking about below knee trauma that requires amputation. For example, all traumatic amputations. All traumatic amputation will be considered to be severe. Then you have 5, which is critical. 5, which is critical. Example like vascular injury. Vascular injury with more than 20% of blood loss. More than 20% of blood volume loss, it will be called as critical. And the last one, that is maximum. Now, in the maximum, we usually see the torso transaction, where the abdomen is transacted. So you have the great vessels transaction, or we can say it is disruption. We call it as the torso transection. Robert, torso transection, right? So this is the score, the severity index, and the various examples that you have. Now you'll say, okay, sir, all this is fine, but how would you look at it? Now, in order to understand how do you calculate the injury severity score, in order to calculate the injury severity score, let's say we will classify them on the basis of the body region. On the basis of the body region, then I will talk about the injury. Then we will see the AIS score. Then we see the AIS score for that particular injury, right? So let's say a patient has come to you with a polytrauma. When a patient lands up to our casualty with a polytrauma, we'll look for all these 3 components which are present. Let's say patient head and neck region, we are going to evaluate. Now that is going to be the first. According to the AIS abbreviation, this is the first thing that you're looking at. This patient is going to have cerebral contusion. Now, if the patient is having cerebral contusion, that is, there is hematoma. Hematoma, according to our scoring system, is given a serious score. A score of 3 is given. So here I would give a AIS score of 3. Okay? Right. The second thing we're looking at face. Face, there is no injury. If there is no injury, a score of 0 is given. Next, we will evaluate the chest. Here the patient is having flail chest. Now a single rib fracture score of 1. But if I say flail chest, that indicates potentially life-threatening injuries where more than or equal to 3 continuous ribs are fractured at more than or equal to 2 different sites, and that will land up in respiratory distress. So critical injuries will become score of 4. Then we will move down to abdomen. Now in the abdomen, let's say patient is having a splenic rupture. There is spleen rupture that is present. Now again it is critical, score of 4 would be given. In fact, when you talk about splenic rupture, which is going to be grade 4, grade 5, I would say it is critical because of hemodynamic instability, score of 5 is given. Then you will look at for the extremity. Let's say in lower extremity, there is femur fracture. Now whenever there is femur fracture, there is excessive amount of blood loss. Right, so that will become more dangerous. So hence a score of 3 is given. Upper extremity, there is no injury. In an upper extremity, there is no injury that is present. So a score of 0 will be given. So this is how you calculate the AIS score. You'll say what is... So like they'll be like all the scores, what is the importance? Now when you come back to our scoring systems, I said IIS is the sum of the 3 highest squares. Come back here. What are the 3 highest scores that you can see? You have 5, 4 and 3. You can say either take this 3 or this 3, doesn't matter. So there are 3 highest scores that you have. So according to this, if you look at the ISS score, it has to be highest score 1, 2, 3 ka square. So 3 square plus 4 square plus 5 square. 3 square is 9, 4 square is 16, and 5 square is 25. I hope I have not goofed up this, right? So if you add 9 plus 16 plus 25, you will get a total score of 50, right? So this is your injury severity score and a total score of 50. And based upon this score, based upon this IIS score, we will categorize the injuries into following components. So what are the injuries that we are going to classify into? We have the minor injuries where a total score is between 1 to 8. Then you have the moderate injuries. Then you have the moderate injuries where the score is between 9 to 15. Then you have the serious injuries where the score is going to be 16 to 24. Then you have severe injuries. You're going to have severe injuries if it is between 25 to 49. Then you have critical injuries. Critical injuries is a score between 50 to 74, and the maximum that it can result is going to be 75, right? Clear? So this indicates the various components of your injury severity score. In fact, ISS is considered to be the most complex way of calculating the injury severity scoring systems, but this addresses all the components that you have. Now, to summarize this, we have another scoring system which is called as TrueMode. We'll talk about it. Another one is going to be TRIS. TRIS stands for Trauma Injury Severity Score. It is Trauma Injury Severity Score. Now, in simple terms, what does Trauma Injury Severity Score does? The Trauma Injury Severity Score, it is going to determine the probability of survival. So what does TRIS does? It is going to look for the probability of survival. We're going to calculate the probability of survival, and this takes into consideration as RTS and the injury severity score. It's a combination of RTS and the injury severity score. So if I say TRIS, TRIS consists of three components. That is your RTS scoring system where you have the GCS coma scale, the systolic blood pressure, and the respiratory rate. Along with that, we'll consider the age of presentation and the mechanism of injury. So you have the RTS scoring system, the age of presentation, and mechanism of injury. This concludes for your TRIS scoring system, basically looking for the probability of survival. Now, whenever you have the extremity trauma, in an extremity trauma setting, you have another scoring system which is called as MES. So one more scoring system that you're going to look in the trauma scores, it is going to be MES scoring system. That is going to be the mangled extremity severity score. It is the mangled extremity. It is going to be the mangled extremity severity score, where we will consider the energy with which the injuries occurred, the status of limb ischemia, status of shock, and the age of presentation. Right? So this concludes your mangled extremity severity scoring system, right? I don't want to go into greater details about the MES. I've spoken in detail about the injury severity score. That is going to be quite important from the practice point of view also. So today's lecture was quite dedicated towards the two components that we spoke about. Number one is going to be your Glasgow Coma Scale in about of disability limitation. We understood how do we calculate the GCS score, its significance, and how are we going to interpret the GCS scores into our clinical practice. We looked at the new component, that is your pupillary assessment scoring systems. We spoke about how do you categorize the head injuries based upon GCS. Then you have expose and examine, lethal triad of trauma and its comprehension, how you're going to prevent it, the trauma scoring system, which is very important. We spoke about the RTA scoring system, how do you calculate it. We spoke about injury severity score, and it's one of the complex scoring systems that we are trying to simplify it for you so that you understand how do you categorize it. This is something that you have to remember, that which patient is going to be quite important and critical for us in terms of management, right? So this concludes our primary survey in trauma. So from tomorrow, or sorry, not tomorrow, from next week onwards, we'll start the secondary survey. We'll talk about each individual organ, its injuries and its management, right? Until then, thank you so much for listening and joining for today. Any questions, any queries, you know where to reach out. You can follow the Instagram channel, that is going to be the surgery guy. This is the same channel that you have on your Telegram group also. All the notes, everything will be shared there as well. It is by my name only. It is Dr. Sandeep Seeram Reddy. So any questions, any queries, if you want to reach out, please feel free to do so. With that, thank you so much and see you guys next week. Somebody is trying to correct the spelling. Okay. Acha, high ki spelling highest. Okay, beta. ठीक है. Thank you. Chalo. Take care. Bye. See you next week.